variants. This is a virus that is mutating, and it is going to continue to mutate unless we stop it from mutating, and the easiest way to stop it is to prevent transmission. And that is where the vaccines are so critical, that if we immunize quickly and at scale, then the issue of variants will go away.
All right, thank you. We have Judith Akolo, who is with Kenya Broadcasting Corporation, and she wants to find out about the trend in Kenya. So she says, my question is, now that we are in the third wave in Kenya, have we reached the peak, or what are your studies indicating?
So, Judith, very good question. Unfortunately, I cannot characterize the trends in Kenya as we've seen the peak yet, but I'm very optimistic that with the measures that the leadership in Kenya has put in place, that the peak will flatten sooner than later, because there are very stringent measures that have been put in place in Kenya, including, I believe, 5 counties that have been actually impacted severely. So we hope to see that the trends will come down. But very interestingly is what we are seeing, that if you compare the first peak in Kenya last year and then the second peak and third peak or third wave, you see that the peaks are increasingly higher. Okay, I mean, it's almost like a mountain that keeps increasing. So the peak of where we are now has already surpassed where we were as a peak a few months ago in Kenya, and that peak, the second peak, was higher than the first peak. So that's what happens with pandemics, because people get into this, what we call pandemic fatigue, and then the virus takes hold and transmit even more. So you continue to see that until we have vaccines there. So the short answer to your question is that I don't think we have peaked yet in Kenya, but with the measures that are in place, we hope that will flatten and then start coming down.
Julia Paravicini from Reuters, she says, what has been the impact for Africa of the stoppage of the Serum Institute production halt, and also the restrictions on vaccine exports?
So I think we discussed this, Julia, last week, that it would definitely impact our ability to continuously vaccinate people. The first wave of vaccines came in through COVAX, and it was predominantly from AstraZeneca from India, from the Serum Institute. And if the delay continues, I really want to deliberately hope that it is a delay, not a ban, because that would be catastrophic if that was the case. Then meeting our vaccination schedule will become problematic, very, very problematic. I think that is common understanding that we wish that there's continuous supply of the vaccines from India, and we continue to engage with COVAX and lend our voices to the fact that this should not be happening, because it will affect all of us.
All right, let me just take the opportunity to remind colleagues of that WhatsApp number that they can use for today's questions. Today we are using the number +251 966 9561. That's +251 966 9561. So that's the number that we're using for your questions for today. All right, now we proceed, and we have another question coming from Judith Okolo, who is with the Kenya Broadcasting Corporation. So she says, my second question is Africa on course to receiving all the doses promised through the COVAX facility, considering that India had planned to suspend exports of AstraZeneca, which is being used mostly on the continent?
The answer is no. That is absolutely no way that, I would be, as always, be very transparent with you that there is no way we are going to meet our needs if India delays And I really want to use the word delay deliberately and not ban the export of vaccines to the continent. I think it's going to definitely hamper our ability to reach our targets. To immunize about, our target was actually to immunize 30 to 35% of our population by the end of 2021. And the backbone of our vaccination program is really, as you have heard from the COVAX mechanism, is the AstraZeneca doses. And if those are delayed, then we are unlikely to meet our targets.
All right. Sarah Jerving with Devex says, can you talk a bit more about the stigma against health workers? How do you see that playing out in the different countries? Do you have specific examples? And what can be done to stop this stigma?
So there's the stigma, as we described in the report, is really the perception that because healthcare workers are treating the COVID patients that they may transmit, which is very, very unfortunate. And that stigmatization has to be fought from at all levels. Again, we need to use the whole of society approach in addressing these issues, which means social media, the media itself, civil society, and other different levels in the community must fight that fight. Because if we allow this to take hold, it will become catastrophic for us to fight COVID and other diseases as a whole. So, but that is the beauty of using science to inform our response, which if we didn't conduct these surveys, you will not know that the perception that people have vis-a-vis healthcare workers. But because we now know, we need to now design intervention programs and or studies that will address those areas. So that's exactly what you do in an endemic. You ask the appropriate questions, find out where the challenges are, and adjust your strategy based on that. But again, it will be my appeal to everyone to be extremely supportive of healthcare workers. Without them, it will be a challenge, and it will be an uphill task to win the battle against COVID-19.
All right. One of our regulars, Bonisile Makubu from the Times of Eswatini, says, is it safe to take the vaccine without testing for COVID-19? What would be the consequences of taking the vaccine when you already have active COVID infection in your system?
So there's no contraindication against taking the vaccine with COVID. We actually know that for people that have been infected before, and when they take the vaccine, they boost. The boosting is very, very high. So I think the literature has pointed to that. So I don't know that it will harm anyone. I think remember these vaccines actually slow the severity of the outcomes. That is in terms of hospitalization and in terms of deaths. So I would not think that there will be a harmful effect with that. With someone who is COVID positive and then subsequently gets the vaccine.
All right, thank you. Lawrence Caramel of Le Monde says, do you still recommend for people to use AstraZeneca in the 18 countries where the B135 variant is present?
Answer is yes. As I've always said, you need to monitor the evolution of these variants. And I would just like to put that particular question in context. If a country X collect a few samples, about 200, and then they find out that of the 200, samples have the variants, then automatically that country is listed as having detected that variant. But does that mean that that variant is predominant in the country? No. And that's why the surveillance, the continuous monitoring of the variant every month through standardized protocols is so important, so that we can know if that is a growing trend or not. If that becomes a predominant trend in the country, then of course it becomes challenging for for AstraZeneca to be recommended in that country. So in other words, if I travel to country X, get to the airport, and in doing that testing, they pick me up and say, well, we tested you, sequence your virus, and the virus is maybe the B135 or B117. That doesn't mean that the whole country has that variant and it should stop vaccinating. So I just want to be sure that we put that in the context, the right context. But it's something that we need to observe carefully over time, because once we see that predominating, then I think there must be a reason to not use the vaccine. But for now, that is not the case.
All right, thank you very much for that. I'm looking at all our platforms, and it appears like we're not getting any more questions coming in. So perhaps this is an appropriate time to ask you to give us your summary. But if another question does come along as you're giving your summary, well, in fact, one has just come in now, and it is again from Lawrence Caramel. So let me put it to you. And Lawrence says, in which countries is that variant predominant? Can you give details about the surveillance protocol?
Yes, let me start with the surveillance protocol. In scenarios like this, you want to be surveying every month, okay, doing a systematic survey every month. And the methodology, that is the method in which you do that, is so important. In other words, if you go to the airport and you sample people that are arriving, and then you report that the variant is predominant, then that is wrong sampling, because you already bias your sampling because of people that are arriving. So it should really be as sentinel sites. You're using sites that are and you do that in the same manner over and over, and every month or every 2 months, so that you can actually compare. Remember, in South Africa, the trend started in October 2020, and because they were doing that in a very systematic way, they realized that that variant became the predominant variant by January. So that methodology is very, very, very important. We see that with respect to the first question, where are we seeing it? I think the countries in Southern Africa, Zimbabwe, I believe Botswana and others are seeing that increase in that variant become predominant as well. I think particularly Zimbabwe, where we've seen the data there. I think that is clearly what you see. But again, it doesn't mean that when you pick one case in a country, that whole country should stop vaccinating. You just have to keep monitoring. So at least I've explained the methodology and what that actually means and where they are predominant in the Southern African countries.
All right. Sarah Jerving has come in with a second question, and she says, are there any countries that have stopped vaccine rollouts because of the uncertainty around the supply of second doses because of India's restrictions? And if there are any that have stopped these vaccine rollouts, which ones are they?
Not that we are aware of, and we are tracking that very, very closely. As you, that's a very important question, and we will be looking into that using our surveillance systems to understand the different patterns and behaviors across different member states. But for now, we just don't. Remember, this just happened last week. So I'm sure countries are still trying to finish vaccinating their the first round of the vaccines that were received.
All right, Julia Paravicini has given us 2 more questions. Let me give you the first one. And she says, following the Johnson & Johnson agreement, how many COVID-19 vaccine doses have the African Union and Afreximbank secured in total, and from which manufacturers? She goes on to say, aside from them and the MTN-funded vaccines, which we have seen already being distributed across the continent, when will large-scale deliveries of vaccines secured by AVAT begin?
So let me start with the last question, Julia. As you read in the announcement, which I think Johnson & Johnson did a separate press release and AVAC did a separate press release, with targeting the beginning of the third quarter, and where you see the large number of doses becoming available, and then they will increase over time. And the beauty with Johnson & Johnson is that the 220 million doses will represent not doses but individuals. That would mean 220 million people vaccinated. That is significant. Okay, very, very significant to put that in context. And I'll actually call it a historic moment and a game changer because it's very different from saying that you have 220 million doses of vaccine. You're actually looking at 220 million people vaccinated. I think that distinction is very important. When we started off with the first announcement that was made by President Ramaphosa, we talked about 270 million doses. Those were based on agreements with the Serum Institute, Johnson & Johnson, and I believe Pfizer. And then, of course, the situation with the AstraZeneca in India with the Serum Institute shifted. I mean, and they were only capable of supplying their vaccines to the COVAX mechanism in Geneva. So we shifted, we pivoted towards Johnson & Johnson for several reasons. One, with the programmatic rollout of that, the single dose vaccination, you can't compare that with the rolling out of 2 doses there. So we are very fortunate that the agreement with Johnson & Johnson went through. So you have 400 million doses of vaccines from Johnson & Johnson. We are in discussions with Sinopharm as well as the Pfizer. Now, the distinction has to be made that until you sign the agreement, you don't have vaccines. So now that we have signed these agreements with Johnson & Johnson, you can actually go out boastfully and say that you have that commitment of up to 400 million doses of vaccines, which will represent 400 million people vaccinated. And that would take us to almost half of or more than half of the population that we are targeting. Remember, our target is to immunize about 750 million people on the continent. If we get the 400 million people vaccinated, then we are actually exceeding half of that. That is the significant and the historic nature of this agreement. You also recall that we had announced previously that discussions were on with the Sputnik vaccine. But that is not secured vaccine. Those are vaccines that we've reached a commitment that they can make it available on the platform. Okay, that is the African Medical Supply Platform. But that is not necessarily AVAC vaccines, but vaccines that can be made available and countries can access them. I think that distinction has to be made. So in short, we are still pursuing additional contract agreements with Pfizer and the Sinopharm, Sinovac vaccine producers.
All right, thank you. We have a question coming from Esther Nakazi. And she says she's a freelance journalist. Her question, has Tanzania shown any signs of applying the vaccine, and have they resumed reporting on the COVID-19 situation in the country?
Not that I'm aware as of last week and this week that they have resumed the reporting, but we are working on that. And also using different channels to engage the leadership of the country the country to see what we can do to re-engage them and offer a technical assistance. And for vaccines as well, that is true for both the reporting and for their vaccination program.
Thank you, John. Claire Keaton from the South African Sunday Times. She says, the Novavax vaccine has proved in trials to be effective against the variant that is dominant in South Africa. Is AVAT looking at that as an option for African countries where the variant is spreading? And she gives the example of Zimbabwe.
Yeah, we're looking at all options. And remember that particular vaccine will be produced in India. And we're really looking at all options. No option should be excluded for several reasons. We want to reach our target soon, and we truly don't also know the longevity of the immunization. So if you get immunized today by a given vaccine, how long it will last. And we also remain uncertain with how these variants will evolve. I mean, would they be a repeated event, and would they challenge the current vaccines that have been used? We just don't know. I've always maintained as a virologist that there's much we don't know about this virus than what we know. I mean, the early breakthroughs have been significant, but as with any virus and many viruses, they will continue to surprise us. So we just have to maintain a strong science base in guiding our response, and understanding how the vaccines will behave post-vaccination is one thing that we should really, it requires an active area of research.
Thank you very much. Let me just remind colleagues again, in case some may be sending their questions to our previous WhatsApp number. Let me remind you that this week we are using this number, +251 966 9561. That's +251 966 9561 for your questions for Dr. John. We move on now, and we have a question that's coming from Ralph Kruger from the German press agency, the DPA. And his question is very similar to the one asked by Robbie earlier on. So he says, how far spread is the new variant from Tanzania so far? And do you have any ideas about its reaction to vaccines?
Very good question. The answer is we don't know how extensive it is or it has spread, but count on us that the network that we put in place is working. And that it is through that network that we were able to pick this variant, because we had to move samples from Angola to South Africa and for sequencing, and the full extent of the characterization of the genomic nature of the DNA of that virus will be published very soon by our group in South Africa and Angola. So just be on the watch out. Now, we will now need to establish surveillance programs in that in the surrounding countries to see the extent of spread of that particular variant. How impactful is this variant on the vaccines? I don't know. All I know is that the receptor binding domain has about 40 mutations that are really, that will be a large number of mutations that can naturally impact the ability to neutralize it, especially with the presence of the so-called the 484 mutant. That is all we know for now on this for this variant.
All right, we have Elizabeth Merab from the Nation Africa in Nairobi. And she says, my questions are in regard to SII's setback to supply COVAX. And I think by SII, she's referring to the Serum Institute of India. So she says, were there any doses to be supplied to AVAT from SII? And if yes, how many doses? And have they been affected by the scale back? Or are you still expecting an impact? I think you've referred to this earlier on, but she goes on to say, I might have missed an answer to this question if it has been asked already. So perhaps you can fill in the missing information that Elizabeth might have missed.
No, we expect that on this platform, some answers will be missed, and we are always happy to repeat certain information. I think sharing the right information, even if we do it multiple times, can only help. So AVAC has not acquired any vaccines from the Serum Institute. We started up in negotiations with the Serum Institute. Those discussions didn't go very far. There were initial promises, but subsequently the Serum Institute preferred to supply vaccines to COVAX, which is all vaccines on the continent are our vaccines, whether they come from AVAC or from COVAX. I just want to be sure that we have a common understanding that there is really the distinction between AVAC and COVAX is very, very artificial. Our goal is to immunize at least 60% of our population. So COVAX is promising us up to about 30% of vaccines. AVAC we're doing our best to complement that and take it to and bridge the gap. So I think it's all very, very complementary. And I think it's what Africa should be doing, that is taking its own, taking leadership and taking its own destiny in its hands and trying to find solutions to solve its own problems. I think the partnership with the Afri-Exim Bank and groups like what Mr. Stripe Masiwa and others are doing is remarkable, because it's really a strong demonstration of the leadership that the continent is showing. So there's really the distinction between COVAX and AVAC, it really has to be seen in the lens of trying to get to 60%. So we have not ordered any vaccines from the Serum Institute. Our vaccines predominantly will be coming from the Johnson & Johnson, as I indicated earlier, to the level of at least 400 million vaccines.
All right, so Julia has come back with a third question, and she says, have the Indian export restrictions changed Africa CDC's position over the AstraZeneca shot? And also, could you comment on whether the African Union will source directly from the Institute itself?
No, we are not planning to source from the Institute directly itself. Again, we work very closely with COVAX. So if the Serum Institute is supplying vaccines to COVAX, we let them do that. Then we explore other avenues. And that's why we pivoted towards the Johnson & Johnson vaccine. So we are not planning to source vaccines from the Serum Institute. However, we are very concerned that any delay will affect the ability of the continent to reach its goals. So we are not indifferent to that. We will be using all different channels and open to us to reach out to India and express our concerns. Absolutely no doubt about that.
All right, so I think we have now exhausted all our questions. Let me just check the WhatsApp numbers. No, we don't have any more questions coming in. So can I then ask you, please, to give us the summary of your main points that you want people to take away from the briefing today?
No, thank you, Wayne. I think the main takeaway is really twofold. One is that the continent is slowly moving towards the third wave, as we have seen and discussed the situation in Kenya. And countries that had experienced the first wave and are now going through the second wave, like Ethiopia, and which is to be expected. And it only tells us that we have to do everything possible to continue to maintain our public health measures that have guided us right up to this point to be able to continue to fight back the virus successfully. I would add that without that, we wouldn't have been able to bend the curve several times as we've done. So again, my strong appeal to the continent is do not relent. Masking is very important, washing of hands, avoiding crowds. And I'm very pleased that many of these countries that are experiencing the second or third wave are implementing, including Ethiopia. I think Ethiopia just released a whole set of new measures to try to fight the second wave. Kenya has released a whole series of stringent measures to fight the third wave. So I think that is what we have in our disposition now that we do not have vaccines at scale on the continent.
Hello, Dr. John. Okay, colleagues, I think we have lost Dr. John there. There seems to be a technical problem from that end. Perhaps we'll just give him a second or two to reconnect, if you can just hang in there with us. Dr. John, can you hear me now?
I can hear you. Can you hear me?
Yes, I can hear you. Please go ahead.
Can you hear me, Wayne?
Yes, I can hear you. We had lost you for a second, but please.
No, I was just concluding that the public health measures will continue to be our most powerful tool until we get to a point that vaccines will be scaled up appropriately. And then the second and last message will be that really that everybody it is our collective responsibility to make sure that people understand that the landscape of vaccines is extremely, extremely challenging, especially for us as a continent. And we are doing everything possible as your continental body, working together with groups like the Afro-Exim Bank, with Strive Masiwa. That is the task force that President Ramaphosa put in place to make available vaccines, but it is a very challenging landscape. I mean, you hear all the pronouncements yourselves on the media from the Europeans threatening, the Indian, the Serum Institute threatening. So it makes it very, very complex, which suggests to me that we will be impacted with this situation over the next couple of months. But we have to remain resilient and continue to deny the virus the opportunity to spread. Those are the only tools that we have in our disposition. Let me just end by saying that during the first wave on the continent, it was almost difficult for somebody to know somebody who have died of COVID. But during this second wave and potentially third wave, everybody knows of somebody who have died of COVID on the continent. That is the difference between our first wave and the last wave, the first wave, the second wave, and potentially the third wave. Now, it's very common that if you ask anyone, do you know of anyone who has been infected with COVID? The answer will be yes. Do you know of anyone who have died of COVID? The answer will be yes. So I think the situation has changed significantly on the continent. I just want to end with that message and saying that we cannot relent. We cannot give in with respect to implementing good public health measures. That is the only the protection we have for now. Thank you.
Thank you very much. Strong points to go out with. But if you will indulge me, since we still have a few more minutes, we have Sarah who's just come in with a last minute question. And she says, when you say that it would be very difficult to reach the goal because of India's restrictions, do you mean 30% by the end of the year?
Yes, excuse me. I mean 30% by the end of the year. If you recall, Sarah, by the June-July timeframe, our doses will begin to come in from the Johnson & Johnson. So that will begin to ease the situation, and hopefully COVAX will be looking at other sources of vaccines. So, but our critical need of meeting the goal at the end of this year is what I'm concerned with. But past that, remember, the take-home message here is the historic announcement, which I really want all of us to celebrate and recognize, is the Johnson & Johnson deal. It enables us as a continent to get assurances that at least 400 million people can be vaccinated. That is huge, it's significant. But the timeline from now to that June period, that gap is what I call the critical gap that we are struggling with. And if we do not fill that gap, then it might impact our targets to be achieved by the end of the year.
All right, thank you so much for taking that last question. You had already given your summary for the day, so I think it is just time for me to thank everyone for joining us and for the continued interest that the media has in continuing to talk about this story of COVID-19, and also the interest in getting the facts so that our people make their decisions based on factual information. So that's it for today. Let me thank Dr. John. Let me thank the crew that was behind the scenes from the African Union, from the Africa CDC, who were able to bring this broadcast to you. So let us meet again next week on Thursday, same place, same time. Bye-bye for now.